What we study is dilated cardiomyopathy. We think that's at least half of the US heart failure cases. We define it as LVE and an EF less than 0.5. Of course, we sort ischemic from non-ischemic, and other causes are relatively straightforward to exclude. And then what's left we consider to be IDC, and we think that's well over 1 million cases, and that's what we study. We do know, based upon the historical literature, that some of that, it's ranged in frequency, is familial. And if it's truly familial, most of us would say, yes, it's genetic, and that's been recognized for a long time. But of course, most of what walks into the clinic, even if you screen family members, appears to be non-familial, and the cause of that has been debated for years, viruses or other kinds of things. And so we've been studying both familial, non-familial, really for a long time. So for heritable disease, the family is the unit of study, the unit of interest. A proband is an individual who brings a family to medical attention. Most of us have been trained to only consider the patient in front of us, so we need to change our view from the patient, the person as a patient, to the proband as the entree to the family who can identify the at-risk relatives. So the difference in these terms, of course, a patient focuses on the individual. The proband defines the individual as a member of the family at risk. Of course, you can show that family as a pedigree. It's extremely valuable. You should do it when you have a new diagnosis of DCM. And of course, it's a transition from a patient-only focus to really understanding this as the patient as a proband, the entree to the family. The DCM Precision Medicine Study was developed with a central hypothesis that DCM, whether familial or non-familial, had substantial genetic basis. It was a family-based study where we found patients, probands, and their first-degree relatives were enrolled. We had 25 US clinical sites, geographically dispersed. OSU served as the coordinating center and clinical site. We aimed to enroll half black and half white patients. We started enrollment in June of 2016, finished closed enrollment April of 2021. We had support from the NHLBI and a supplement from the Genome Institute. The specific hypotheses are shown here. The first, 35% of IDC is familial. The second, similar proportions of familial, non-familial have genetic cause. Third, similar proportions of DCM of European or African ancestry have identifiable genetic cause. And then the fourth was a tailored intervention to help DCM probands communicate DCM risk. It's a communication aim. Will improve the uptake and impact of their activities to assess that risk. So in the probands, the crude and model-based estimates of familial DCM was 11.6% overall. That's just taking the simple math and just looking at it. The estimated prevalence was 29.7% overall with highly significant confidence intervals. The estimated prevalence of familial DCM by race, 39.4% in black, 28% in white, with no difference in Hispanic and non-Hispanic. Now the crude prevalence of an expanded definition, this is with this LVE, LV systolic dysfunction only, was 24.1% overall, and the estimated prevalence of an expanded definition of familial DCM, 56.9% overall, with no difference between black and white probands. So the key messages, at least of this part of the talk, is that familial DCM is prevalent. It's increased in black patients. The younger the proband, the greater the risk to FDRs. And it certainly supports the guidelines, which this is not a guideline-based talk, that's something different, but you need to take a family history. Clinical screening of the proband's first-degree relatives is indicated to assess their risk. And then counseling of at-risk relatives is indicated, and genetic testing for those where you indicated in first-degree relatives if you have a finding in the proband. So the bottom line, you can find actual DCM or early evidence when you screen families. We surmise you can prevent DCM and thereby prevent heart failure. So you can do this. The cohort was widely representative. I think that's really important. This is not a one-off. Yes, it was at transplant centers, but we really got a very broad range of patients. And then the final comment is, it's always surprising what you find when you look for it. Now, what we observed were fewer tight and truncating variants in African ancestry, and it was not subtle. It was like big time. There had been one previous suggestion of this in a report that didn't have enough numbers to really get to statistical significance, but not quite half of African ancestry had fewer tight and truncating variants compared to European ancestry. Also then, there were fewer variants in the non-titin definitive strong evidence DCM genes. Nevertheless, there was a highly significant association of titin truncating variants with DCM, so clearly titin is highly relevant if you find it in an African ancestry patient. There's fewer numbers of those truncating variants found. So let me just summarize this. The conclusion is that DCM genetic architecture differs. It differs between patients of African ancestry and European ancestry. There are fewer actionable variants and more VUSs, as shown, and fewer truncating variants, more missense variants. The titin, I show the titin there. And then less data from African ancestry, importantly, less data from African ancestry patients available in our clinical databases. The reason for that is almost all the sequencing that has been done in white patients, European ancestry.